we're going to start. This clock is 3 minutes fast. Students get out of class sooner when it says that. So welcome everyone. We're thrilled to have you all here. And we also are pleased to welcome those of you who are watching us through live streaming today. And we're delighted to have Dr. Ken Prager talking about must we always obey the healthcare agent. Dr. Prager is professor of medicine and director of medical ethics and chair of the medical ethics committee here at Columbia University Medical Center. He trained at Harvard and has won many awards for his teaching and superb work. He's also written widely for the New York Times and other publications. Before he speaks, we're delighted to introduce Barbara Rothschild. Barbara is an internist who is a core faculty member of our master's and certificate programs in bioethics. She's been teaching medical ethics for 17 years, 7 years with us, 10 years before that at University of North Carolina, Chapel Hill. She's a superb instructor who's written widely on a number of issues, and I'm pleased to have her speak briefly about our program first.
I just want to take a minute. I hate to take any time away from Ken Prager because he's such an amazing speaker. But to tell you a little bit about the master's and the certificate program we have in bioethics, because I have a lot of clinicians in my class. I teach Introduction to Clinical Ethics, and I just wanted to give you some feedback that many of them have given me afterwards, which is something that I think we can all relate to, is this feeling of moral distress and sort of job dissatisfaction within medicine. More and more we're seeing statistics that are showing a lot of physicians, a lot of nurses unhappy, and at the core of that sometimes unhappiness is seeing things they can't do anything about or observing situations that they feel uncomfortable with and not really knowing how to think about it or how to talk about it. So I find that a lot of the people in my class after the class and after the course, after the certificate program, have found they report a lot more sort of satisfaction with what they're doing. They feel more empowered. They feel like they can talk to colleagues. They can talk to administrators about what they're seeing and get constructive feedback and also give some constructive ways that they can fix some of the issues that they're seeing. So I wanted to use this opportunity, if you're joining in with us and have not sort of participated in the program, to take a look at the website, take a look at the certificate program. It's 4 classes, or the master's program. Here at Columbia, it's very flexible. Many of our classes are online. And I think you would find a lot of satisfaction. And Ken does a guest lecture in my class almost every semester, and he's beloved by my students, so we should all look forward to this. Thank you.
Thank you, Bob, and thank you, Barbara. And welcome to everybody. Good afternoon. I'm going to speak about a case an actual case that we had at Columbia, which I consulted on in my role as the ethics consultant. This was a good number of years ago, but it was a very interesting case and raises a lot of issues that are germane today. Must we always obey the healthcare agent? I'm sure all of you know a healthcare agent, sometimes referred to as a proxy, in other states it may be referred to by other terms, is an individual that is designated officially by a patient when the patient has capacity. And that person can be anybody over 18 except for the patient's physician. At least in New York, that's what the law says. That healthcare agent can make decisions for a patient when the patient lacks capacity. Medical decisions, often life and death sorts of situations. And the question that I'm raising over here in this talk is, what if we as physicians and healthcare providers in general feel that the agent is making a decision which is inappropriate, unethical, unsound? What if we question the mental capacity or the mental status of the agent? What do we do in a situation like that? And so with that as the preface, let me present to you the case. And I've changed some of the details for purposes of privacy. This was a 66-year-old man with a history of treated prostate cancer. He had been a heavy drinker until 25 years before coming in the hospital, and he had had 3 prior transient ischemic attacks, but no neurologic residua. He was basically fully functional prior to this incident. And he was admitted to the hospital after being found unconscious by police in his apartment with head trauma, and the walls of the apartment were splattered with urine, blood, and feces. His wife had called the physician when she did not hear any response. There was also a almost empty bottle of tequila which was found at the bedside. The patient's wife had spoken with him the evening prior to being found by police. They had 2 residences, and she happened to be at the other one, but when she phoned and he didn't answer, she was worried and called the police. The patient was brought to the hospital, and he was intubated to protect his airway because he was unconscious, and a workup showed that he had significant trauma to his head and his brain. He had a right temporal intracranial hemorrhage, right temporoparietal skull fracture, bilateral frontal lobe hemorrhages. There was an intracranial pressure device which was placed, and the patient was treated appropriately for high intracranial pressure. He was also treated for a cardiac arrhythmia. Now, the patient's wife, who was his healthcare agent, she expressed immediate concern about his neurological recovery, although there was one chart note on the second day of his hospitalization which says, quote, "The wife wishes to continue with current level of care and rediscuss prognosis in 1 week," unquote. After several days, however, she began requesting removal of life support. She wanted him taken off the ventilator and all treatment stopped. Allow him to die. Now, the patient's neurology attending was very concerned by this request. And when she asked him for, "What is my husband's prognosis?" he said, this was the director of the neurological intensive care unit, and granted that all prognoses have to be taken with some grain of salt. Nevertheless, we need some ballpark estimate of what the prognosis is. So he said that the patient had about a 35% chance of an 85% to complete neurological recovery in a year, a 50% chance of regaining limited independence with severe disabilities, and a 15% chance of dying. These were his estimates. Now, because the neurology attending was very uncomfortable with withdrawing treatment and allowing him to die after such a short time, and what the attending felt and the other physicians and nurses felt, there was a reasonable chance of an excellent recovery, according to his estimate, about a 35% chance that he would be normal at the end of a year. He called for an ethics consult on the 11th hospital day. The wife at that point was refusing a tracheostomy and a PEG, a parenteral feeding tube in the stomach, which was felt necessary by the physicians. Now, a little bit of history. When I saw this patient's agent, she told me that the patient had been a very great athlete in his youth. He had been married. She had been married to him for 26 years. And he led a life of ease after the marriage. Those are my terms, not her. He was basically supported by his wife, and he loved sports and travel, and she was working hard, and he was enjoying the benefit of her income, and it was a very wonderful relationship. However, 5 years before this admission, he was treated for prostate cancer, and this left him impotent, which was a great source of upset to him. Because of the wife's business reversals also recently, he had to start working, and he did not like his work. He stopped taking the medications that he had had. He had been taking some medications for his prostate, for the TIAs to prevent them. He stopped taking all his medicines about a month before admission, and his wife wasn't clear why did he stop taking his medicines. And 2 days before admission, he told his wife, although there was nothing acute at that time in his medical situation, he did not feel that he had long to live. Now, the patient's wife, she wanted to withdraw treatment and allow her husband to die because she did not feel that he would want to live with the degree of disability that was most likely awaiting him. Again, going back to prognosis, most likely, remember that the neurologist had said he's got about a 50% chance of surviving with significant mental disability, a 15% chance even of dying, so that's 65% chance of some disability or death, but a 35% chance that he would be totally normal. And she said that he wouldn't want to live with the degree of disability that was most likely awaiting him, and it was most likely based at least on the prognosis of the neurologist. She also felt that he wouldn't want to put in the effort at rehabilitation that would be required. Even if he could get to be back to 100%, it would be a long course. He'd have to go to rehab. You need a motivated patient. She didn't think that he had what it took to do it. And she was very pessimistic about his chances for recovery, and she actually said it would take a miracle for her to be able to walk into the neurologist's office in a year. Now, this woman was not a physician, there was a very great chance, we said using those numbers, about a 85% chance that he would be alive at the end of a year and walk into his neurologist's office. That's not a miracle, but in her mind, she felt that there was no way that he was going to survive. She was quite concerned also over the financial burden that her husband's medical and rehab needs would place on her, and she was open about this. And it was a realistic appraisal on her part. She refused permission for a tracheotomy because she told me it would make her husband look like an animal. Those were her very words. She also refused the feeding tube. Now, she had never given much thought to the possibility that her husband might have been depressed prior to the episode that led to his hospitalization. I found that rather strange. The patient had stopped taking his medicine a month before. Remember that he had become impotent, which was a great blow to his ego. Remember that he had to go to work. He wasn't happy with his job. And 2 days before this happened, he said he didn't think she had long to live, but it never occurred to her that he might be depressed, and he certainly never went for any psychiatric evaluation. Now, the patient did have a written living will, and it did not state that the patient, his agent, knew his wishes concerning artificial nutrition and hydration. Now, this took place before 2010, when the Family Healthcare Decisions Act was enacted in New York State. At this time, when this patient was a hospital patient, according to New York State law, he could not be deprived of artificial nutrition and hydration even by his healthcare agent unless she could produce clear and convincing evidence that he would not want to have artificial nutrition and hydration. We did not have that evidence, either verbally or written. So by law, at least, she could not technically refuse his getting artificial nutrition and hydration. However, by law, as his agent, she could request that he be removed from life support, so the issue might become moot, actually. But I mention this. When this was mentioned to the agent, that she could not, by law, withhold artificial nutrition and hydration, she became very angry, and she implied she would take legal action to enforce her wishes if necessary. She was a lawyer. Now, here are some of the ethical issues. Obviously, the key issue here is patient autonomy, and how do we get patient autonomy? How do we assess it? Well, we go, obviously, from verbal statements, and we ask the wife, had he ever spoken to you about what he would or would not want if certain things happened to him? She said, well, when a friend of his was left significantly impaired by a stroke, my husband made me promise that I would never let him end up in that condition. How severe the stroke was, I'm not quite sure. That's what she relayed. And he could never have addressed the precise situation he was now in with a reasonable but not excellent chance for a complete recovery. What would he want? I challenge you or me. We don't sit around when we make our living wills and say, well, if I have a 35% chance of a complete recovery, Jeannie, my wife, keep me on the ventilator and feeding tube. If it's 27%, I think that's out of the question. 35 and above, I will. The point is, we can't, our living wills can only be so specific. They cannot deal with minutiae like this. And besides, who knows if the neurologist's prognosis is even correct? Maybe somebody else will disagree. So, but that's why we need an agent, and the agent should exercise, as you'll see, what we call substituted judgment. We'll get that to a minute. Now, the patient also did have a written advance directive. This is another way that people can make their autonomy expressed. What did the living will say? It was one of these boilerplate living wills, which are not terribly helpful, and this is what it said. Life-prolonging measures be withheld in case of a, quote, terminal condition. This man did not have likely a terminal condition, the likelihood that he would die within 6 months. It was quite unlikely. He was a strong, fit guy, not that old, and none of his vital organs were affected, except his brain, of course, but that would not necessarily be life-limiting. So he didn't want he didn't want life-prolonging measures in case of a terminal condition. Didn't really apply, or in case the physicians feel there is no medical probability of my recovery from such a condition. Well, you heard what the numbers were. Did he have no medical probability? No, he didn't. He did not have no medical probability of recovery from such a condition. He had a reasonably good chance of a full recovery. So neither of these so-called triggering events applied at present, namely that I want you to pull the plug if A or B. A or B did not seem to apply over here. Now, of course, patient autonomy is also exercised by allowing us to appoint a healthcare agent, and he did, his wife. How can we know if the patient would reject, I asked this before, a 35% chance of complete recovery in a year and choose death over his probability of recovery? We can't know that. He appointed his agent. Presumably, she makes that assessment for him. The purpose of a healthcare agent, then, is precisely to guide treatment in a situation such as this, where we are unsure of what the patient would want, and the advance written and verbal directives do not strictly apply. That's why we need a healthcare agent. Some people don't even bother with a written living will because of these problems that I encountered, the boilerplate generalities, these 35%, we can't envisage. So we pick somebody that we trust, and we have a discussion with that person, and we say, here are my general feelings, my philosophy about life and death, and I trust you to make these decisions. Now, the agent, this woman, presumably knew the patient's wishes better than anyone, that's clear, but he never discussed his wishes in such an unforeseen event as this, so how accurate could the agent's request be? Thus, the best the agent can do is to provide us with what we call, I used the term before, substituted judgment. And this has been found to be a poor predictor of patient wishes in past surveys. There have actually been papers that have been written where people with end-stage heart failure, cancer, COPD have been said, here's a scenario, what would you want in this case? And they give their agent or they give their surrogate the same questions, and then they see if there's any correlation. The correlation's terrible in general. The better correlations occur when people have had discussions with their surrogates, with their healthcare agents. But in many of the cases, it's like flipping a coin. You think you might know what your loved one would want in this circumstances, but there's just as good a chance that you would be wrong. Nevertheless, as bad as the accuracy of surrogates and agents are, the accuracy of the physician is even worse. I certainly can't make the decision. The neurologist couldn't make that decision. So we have to do the least bad one, which is obviously the patient's healthcare agent. Now, obviously, there is this countervailing principle of beneficence. Why did the doctors call an ethics consult? Because of beneficence. They feel this is inappropriate. I want to help this man. This man has a reasonable chance, we think, of making a complete recovery. What happens then when a physician feels that their duty to be beneficent clashes with what they feel are unreasonable wishes of the healthcare agent? In this case, the physicians felt the agent's rejection of aggressive treatment in the face of a 35% likelihood of complete recovery was ethically problematic, and that's why they called for help. Also, the woman's manner as well, that she was so fixated. She was fixated, like pull the plug. It grated against the doctors. This seemed to be somewhat inappropriate, her behavior. In addition to their concerns, one of the agent's motives, in addition to their concerns about the unreasonableness of the medical judgment or demands of the agent, the doctors felt that in their discussions with her, she was focusing repeatedly on the effect this was having on her and her concerns about finances, her concerns about what this will do to me. That again raises your suspicions a little bit or makes you feel very uncomfortable about withdrawing life support. So given the primary ethical responsibility of doctors to their patient, they felt that the agent might not be making decisions primarily on the basis of what was best for the patient or what the patient would have wanted. And adding to the concern of the physicians about the agent's decision-making, in a follow-up discussion with the ethics consultant, namely myself, this lady said to me that his current care wasn't warranted because her husband had only a 30% chance of recovering some mental functioning after a year. That's not what we said. He had an 85% chance of recovering some mental functioning, a 35% chance of being totally normal. So this was grossly incorrect based on the neurologist's prognostications repeatedly relayed to the patient. And if her decision to withdraw care was then based on a terribly skewed estimate of his chances for recovery, how could her decision be ethically acceptable? You would like, granted she's upset, granted this is a stressful situation, but you would like to have the agent at least giving back some of the information that you have given them upon which her decision is based, that is based on what was actually told to her. What we decided, and this was, and I must say that this lady sort of grated against me as well. And I was concerned that she was not thinking rationally, clearly, and seemed to be so focused on just getting this over. She was overheard by the nurses saying, "I wish my husband would die." The nurses relayed this to me. This is not the usual type of behavior that we've seen, even in people who, even in families who are terribly upset by tragedies that occur to their loved one. Nevertheless, in weighing all of this, I felt that this is something that I certainly did not feel I should take upon myself to decide, and so I called, in a rare situation, an emergency meeting of the Ethics Committee, and a number of the people did come by, and I wanted to also have somebody other than this lady weigh in on this man, on what this other person who might be thinking more calmly and rationally might have to say to either validate or not validate the wishes of the agent. And so we sat down, and who was this other person? The only other person that she could think of who really knew her husband was her, the agent's father, the father-in-law of the patient. So the father-in-law came in. We had a meeting with the agent and her father. Now the father was cool, calm, and collected, and he did seem to make a compelling case, stressing that his son-in-law was extremely vain. He had focused on his appearance and his athletic prowess all his life, and he did not think that given the odds of full recovery and so forth, that he felt that his son-in-law would rather be dead than face the odds of only a 35% chance of a full recovery. They both felt that there was no way the patient could tolerate any degree of disability at all, nor quote the indignity of a tracheostomy and a feeding tube. These were their words. And so the question arose then, are there any circumstances under which we may not ethically or legally obey the healthcare agent? So we've heard from the agent, we've heard from the father-in-law, and we have to make a decision. And here, I'm digressing to give you this is an actual advance directive of one of my patients who gave this to me. I kept this. A nice fellow, by the way, who in all other respects was normal. He wrote, "I direct life-sustaining treatment be withheld or withdrawn if," and then I don't remember what the if were, but he said, "Let it be known that I do not want any life-sustaining treatments," this was handwritten, "unless I can be guaranteed that I will be able to experience the very same quality of life that I enjoyed prior to my illness or injury. My fear is not death, but the emotional and financial stress of burden that my illness and or injury will inflict on my family. Therefore, allow me to die with dignity and respect." Now, he says, unless he can be guaranteed, give me a break. I can't guarantee that I'll get home safely tonight. I mean, this guaranteed. What if he has is in an accident, is briefly unconscious, and it turns out that we have to amputate 3 of his toes? This will have an impact on his walking. It won't be the same quality of life. Would he rather be dead? I mean, this is outrageous, and yet this was a written, living will. I put this here as an extreme and crazy example, but a true life one, of what some people actually have in their minds. Now, would he really want to die rather than experience some mild degree that might impact on his quality of life? I don't think so. I think if he were staring the angel of death in the face and they said, "You're going to have some weakness in your left arm. Do you want us to let you die?" Nobody in their right mind will say, "No, a little weakness, I can't do my barbell thing anymore, let me die." It's nonsense. And yet, this is the sort of stuff that we have to deal with sometimes. Now, the law, which presumably is a bit more rational than this sort of advance directive, what does the law have to say? Can we ever not listen to a healthcare agent? This is New York State law. It says the healthcare provider, members of the principal's family, a close friend of the principal, may commence a special proceeding in a court with respect to any dispute arising under this article, including but not limited to a proceeding so if we want to challenge in New York State a healthcare agent, we have to go to court. And this proceeding we can determine the validity of the healthcare proxy, the actual piece of paper, whether it's forged or whether it had not been filled out properly. But here, 2 and 3 are the key issues. We can have an agent removed in New York State on the ground that the agent A is not reasonably available, she was, willing and competent to fulfill his or her obligations, or is acting in bad faith. That is really the only legal criterion for removing somebody, other than somebody who might be incompetent, somebody who is flagrantly psychotic, for example, or demented. If a person is not psychotic, demented, if the patient, we have to prove that that agent is not acting in good faith. That's a very hard thing to say. And number three, we can override the agent's decision about healthcare treatment on the grounds that A, the decision was made in bad faith, or not in accordance with the standards, etc. Was this lady acting in bad faith? I don't think, frankly, that we could go to court and prove that. I think we had problems with it. I think we had significant reservations. I think the doctors were appropriate to call an ethics consult. But I think to show that acting in bad faith means that she has an ulterior motive. She has an agenda. And that's very hard to prove. And frankly, the few times that I've had that brought to me as a healthcare, as a consult, I have found that the doctors have usually been dead wrong when they question the motives of a person who is making a decision. In terms of the immunity for me as a physician, let's say we had removed this man from the ventilator and he died. Would I be immune from prosecution? No healthcare provider shall be subjected to criminal or civil liability or be deemed to have behaved in unprofessional conduct for honoring in good faith a healthcare decision by an agent. If I can act and show and demonstrate that I as a physician am acting in good faith based on appropriate criteria, based on appropriate discussions with the agent, and based on an appropriateness given the clinical facts, I can't be subjected to criminal or civil liability. What about the agent? Can she be sued? No person acting as agent pursuant to a healthcare proxy shall be subjected to criminal or civil liability for making a healthcare decision in good faith pursuant to this article. So if the agent is acting in good faith and the doctor is acting in good faith, we are protected. We cannot be sued. Now, what about other ethical issues in me, whether I should follow or not the request of an agent? Physicians may choose not to follow the request of an agent if that request violates the physician's professional or ethical standards of conduct. We may have moral qualms about doing that, about removing life support in a particular case or even in general, but we can't abandon the patient in that situation. I would have to attempt to find a physician who would be willing to carry out the agent's wishes. And if I can't find any other physician who is willing to carry out the agent's wishes, then perhaps it says something about the agent's request. And so I can't simply abandon the patient. The physician ought to be able to defend his or her action in case of legal challenge. Given the legal powers of an agent, the onus would seem to be on the physician to justify not following the wishes of the agent. Now, getting back to our case. So the committee met with the father-in-law and with the agent. We felt that although the request of the agent was unorthodox, to use a term, there were not compelling reasons not to listen to her. We did not feel that we could say with certainty she was acting not in good faith, and the reinforcement by the more sane appearing father-in-law made us feel better about carrying out her request. She did not appear to be acting in bad faith, had no evidence of mental impairment. Both she and her father made a strong case that this patient was unique in his reliance on his physical prowess, appearance, and independence as the main reasons to live. However, let's come back to the issue of depression. Was this patient depressed? Was his head trauma the result of a suicide attempt? He hadn't touched alcohol for 25 years. A nearly empty bottle of tequila was found at his side when the police came. So something cracked in this man, presumably. He drank, led to his falling, severe head trauma. He had never seen a psychiatrist, never been under treatment. Question, should he be allowed to die without any psychiatric evaluation and attempt at possible treatment? Maybe he had a treatable depression. If somebody tries to commit suicide if somebody tries to commit suicide brought into the emergency room, we don't look and say, well, this is an appropriate attempt at suicide, we'll let them die. We get patients better and then we deal with the outcomes of that later and have the patient see a psychiatrist. But the question is, would treatment still be possible? What if he had brain damage as a result of his head trauma? Would it even be possible? Or perhaps the brain damage will remove his depression. He will no longer be depressed. These are all legitimate and serious questions that relate to this case. So does the issue of possible depression alter the ethical calculus of this case? The fact that this man had never seen a psychiatrist and never been treated. And then the other ethical reservations, which I've said before: to what extent was the agent's request motivated by her needs and anxieties rather than by the presumed wishes of the patient? Her statements to the nurses that she hoped her husband would die created a degree, that's very unusual when you hear people who say to the nurse, I hope my husband will die, and said this repeatedly. This created a degree of discomfort among his caregivers that was significant and raised questions about her role as an agent. Let's see what happened. Okay, actually, let me pause over here. We do have some time. What do you folks, you think what would you do? Would you extubate? Well, you can see on the slide, we did extubate the patient. I should have held that slide and so forth. Any thoughts here about what's the right and ethical thing to do in a situation like this? You go ahead, extubate. Should he have been extubated on the third day? Was, stalling for 11 days before an ethics consult was called? Was that appropriate? What do you folks think?
Was this planned for terminal extubation?
Well, okay, good question. Would he have died if we extubated him?
So was this an attempt to save?
Yes, she wanted him dead, and she wanted him removed from the ventilator so that he could.
So the plan was to extubate him, and if he died, he died. It
That's
wasn't
correct.
To do a trial.
That's correct.
Of extubation,
That's correct.
and if that
He would be do not
was
intubate,
successful, he
re-intubate.
was not
That's
reintubated.
correct. That's correct. Her wishes were very clear. She wanted us over. So, yes, sir.
There's a question from our live stream.
Oh.
Gerald Newberg has a question.
Oh, Jerry.
And he's asking, was there an option to negotiate a trial or treatment for another 1 to 2 weeks with NG tube, but without trach, then reassess prognosis?
She wanted her husband dead. There was no question of a trial, because the issue over here was not so much his physical ability to survive the extubation, it was his brain. And she felt that she could not be guaranteed a good enough prognosis that he would be the same person that he was before to warrant his continuing to live. So there was no trial of, the likelihood that he would wake up and be his normal self in 2 weeks was zero. He had significant brain trauma. This would take, as the neurologist said, this would take a good year. But it was possible. So there would be no negotiating over here, really. She wanted this to be over. Rob?
Any sense of what their marriage was like before this?
It's hard to know what the marriage was like. I call it a symbiotic relationship where, we use the term a trophy wife. You've heard of that. I think he was a trophy husband. I think this was a good-looking guy who was very athletic, and she was very happy to have him at her side, go to parties, and he was a great athletic guy and played tennis with his father-in-law, et cetera, et cetera. So it seemed to be a good marriage, I would say, but we didn't go into it too much. Yes, David?
Ken, did you have a chance to explore with the wife? Did you have a chance to explore with the wife the reason for the change in her attitude from the initial progress note where the wife said, I'd like to give it a week or two and see where we stand, to when she said, no, enough?
Yes. I think that as she came into the hospital, like on day 2 and 3, and looking at the situation, she just became convinced that this was terrible. She had a very negative view, by the way, about the medical community in general. This whole issue about a tracheostomy, making him look like an animal and so forth. I just think it sort of seeped in like more on day 3. And whereas when she first came in, I think she was in too much of a state of shock. But when it seeped in and she looked at him and saw the amount of life support he was requiring, no go, this is not going to happen. And she could not conceive of him actually getting back to his normal state. That's why she said it would be a miracle if he came by, if he even survived for a year.
Yeah, this is a great illustration of false precision and the way the numbers get gamed in people's minds, because what it said on your slide was that he had a 35% chance of an 85 to 100%
chance
recovery.
of it, right.
Now, your language shifted to the
Yes.
100% end
I-
of that.
I-
And I understand
I
that.
wanted to simplify it, but
Yeah.
85% of 35% is a little less, so we can say that's okay.
But the point is,
Yeah.
I think she may have been influenced by this false sense of
Yeah.
precision and sort
Yeah.
of lost whatever hope she may have been keeping open, reflected in the initial progress note.
Yeah. And yet, when you asked her afterwards, you know, she came up with it would be no chance of him surviving even a year. I don't think she processed it all. I think this was more of a gut feeling, looking at the whole picture. He looked awful. He was on life support. There's no way he's going to be the same man again. And who knows if she also had in the back of her mind the fact that maybe he had been depressed since his, he wasn't quite the same person, had said to her 2 nights before that he didn't have much longer to live. I don't know what was going through her mind, but I think your point's well taken. Yes, Barbara?
And to your point, I think it's interesting. You referred to 35% as a reasonable chance. And reasonable means many different things to many
Yes.
different people. And so this just opens that door on how difficult this is in communication. And her, quote unquote, misunderstanding has a lot to do with just the way we present information to patients. But I was also going to say that I think this is such a great case, so thank you so much, about healthcare agents and why do we have them if we're not going to believe them, right? I mean, if we built this whole enterprise around healthcare agents, they're supposed to tell us values and preferences, and we have to accept that sometimes those values and preferences don't match our own, and the way people behave is not how we would behave, and the way people talk is not how we would talk. But the purpose of the agent is to enable that to be the case and to still follow those wishes. And I think this is a great case about still this makes us deeply uncomfortable, but the system is there for a reason, just for this very thing.
I agree with everything you said. I would just put the caveat that if she had acted in a more quote-unquote reasonable way, I don't think there would have been as much discomfort among the caregivers, but she did not. But you're right. Why do we need healthcare agents? As I said before, it's for the tough questions. This is a tough question. And 35% may sound reasonable to me and unreasonable to somebody else. But she didn't appear that way, wasn't processing. Once we met with her father, then we decided, and I'll go on now, we extubated the patient. Well, we extubated the patient, but the patient did not die, and he did not aspirate. And he became alert over the next week. He actually became alert over the next week. He regained the ability to swallow food. Now, initially, the wife was delighted to see her husband regaining awareness and being able to interact and smile with her. And I'm going to skip to this slide. She emailed me. This is from her email. I have renewed hope and visit daily. Just the sight of his beautiful eyes and smile keeps me thinking that perhaps you were right and miracles can happen. I thank you for your optimism, which is so important during this time in our lives. He is the love of my life, and to think that there is a chance that we can be together at some level would be the greatest gift possible. You have given me hope that there is a chance that we may have another chapter in our life together, a different chapter, maybe even a better chapter. Wouldn't it be nice if the story ended here? Everybody would live happily ever after. This is such an important email, though, because it shows you, well, first of all, I think it shows you that she loved her husband and how happy, and she's even saying, you were right. You know, she was willing to say, and so isn't that great? Okay, let's continue. The patient was transferred to a rehab facility. Over the course of weeks and months, he improved medically but never regained his prior mental status. His wife was initially very thankful for the treatment her husband received. I just showed you her email. But as it appeared clearer that he would not improve to his baseline level, she became extremely angry over her husband's eventual condition and blamed the physicians for having saved her husband's life. 6 weeks later, another email. We have no relationship. I am a caretaker, feed him, etc. He will not shower or take his medications and doesn't remember from day to day. It is exactly why my father and I begged to take him off the respirator immediately, because this was not what my husband or I wanted. 2 months later, my husband gets worse each day. He has no cognitive abilities, no initiative, hates being incarcerated in a nursing home, doesn't eat, doesn't know who I am, and there is no quality of life for him or me. I have since changed my living will. It is so specific that even an IV cannot be put into me. I will never go to a doctor again, as they cannot be trusted. My husband should have been taken off life support as soon as he entered the hospital. There is no chance he will ever have a life. The only establishments who gained were the hospital and nursing facilities. So again, this was about money, not humanity. I shudder, sick, each time I see the condition you left him in. And notice when she felt that he might be better, we were heroes, how wonderful. When it didn't work out that way, we were devils, we were horrific. This is I circulated this to all the members of the committee. One of the committee members, I'll show you two different views from members of the committee. Who says that a 90% chance of full recovery is substantially different than an 80% chance, what we said before? Who chooses where to draw the line? People who opt for a proxy want that person to decide, not a committee or a collection of their caregivers. It's all about who decides what set of odds are acceptable and what set are not. There is no right number for any of these choices other than 100% or 0%. Every other choice, it seems to me, is in the eye of the beholder. If an individual says, I'd like my wife, mother, mate, brother, or whoever to make that choice for me, why should anyone else intervene? And if one would like to intervene, what are the criteria for deciding whether the proxy is being inappropriate or simply deciding what they truly believe the patient would like? One view, one member of the committee. Another view. I think we should continue to handle decisions with a careful, shared process that respects proxy power, but factors in medical appropriateness and includes safeguards that keep everyone accountable. I'm sure even a proxy has legal as well as ethical accountability, i.e., could another family member sue an impulsive proxy for giving up too soon against medical advice? What if a proxy became mentally unstable? We still have a duty to advocate for the patient. So could this outcome have been prevented? The outcome, the only way this could have been prevented is if he had died, if we had let him.
Medical outcome.
Could his neurologic, in other words, she's miserable, understandably, that her husband is nowhere near the person he once was. Could this have been prevented? The only way to prevent it would have been to take him off the ventilator day one and let him die.
Just clarifying, if you're talking about the patient's medical outcome or the outcome for the family unit?
I think the two are linked.
They're linked, but they're not the same thing.
Well, how would you distinguish?
Because you could have a situation where the patient's medical outcome, the patient died or the patient had a complete recovery or the patient was in some intermediate state. And you could also have an outcome of the wife having perhaps not a different relationship to her husband's disability, but having a different relationship to her feeling reconciled about what happened.
In other words, could we have helped the wife overcome her unhappiness and anger given the medical outcome? Is that what you're saying?
Was there something about the process that could have left the wife distinct from her relationship to her husband and her feelings of ambivalence and anger and loss with related to her husband? Where could there have been a process in the interaction with the medical providers that left her feeling more that there was an allyship and that it was a supportive and restorative process for her, regardless, independent of the relationship that she has with
Yeah.
her husband?
I don't know the answer to that. I can only tell you that we tried to be as understanding and as supportive as possible. And I think everything with her was very black and white. Either he gets back to be the man he was before, in which case the doctors were great. If he's not like he was before, the doctors are villains. And I don't know that there could have been, maybe perhaps there might have, we did try. She was there obviously a limited time. He went to a rehab facility. I don't think that we could have altered her view of this, frankly. But yes.
I'm just curious about the process, because you talked about challenging the proxy. challenging the proxy. How long does that take in the court? Like, could you use that? Could you use going, because courts operate very slowly,
That's right.
So conceivably, could you buy 2 or 3 weeks' time by challenging?
I think that if we had gone to court, and I don't ever recall once in 25 years I've been doing this, us ever having challenged the proxy to go to court. But had we, I think you're right, it would be slow, and there's a window of opportunity in a case like this for letting somebody die. The longer they go and don't die, the stronger they get, the less likely they are to die when you take them off the ventilator. And as you see, he recovered. Had we extubated him on the very first day or second day, he probably would have died, or complications or aspiration. So going to court, maybe the court would have ruled in her favor, but it would have been too late to allow him to die.
Yeah.
You see, there's this window of opportunity.
But that basically never happens.
Well, no. Again, I think for us to prove that she's acting in bad faith, I think would require a very high standard of proof. And I don't think and as you see, we were called for an ethics consult day 11 of his hospitalization. I think by then it was already too late for him to die. We extubated him 2 days later, after I saw the lady, saw the patient, called an emergency meeting of the ethics committee. I think we acted on the ethics part rather expeditiously and have him extubated in 2 days. Yeah. And just before I call you, I just want to finish this slide. How early in the patient's course, realizing that the earlier in the course, the more uncertain the prognosis, and therefore the more difficult it is to arrive at a treatment decision that might be construed as reflecting the patient's wishes, how early could a decision about supportive treatment have been made? And finally, I leave you with this question: how much control over our medical destinies can we reasonably have? You know, we can fill out advance directives and we can appoint healthcare agents. Things happen, and there's only we would like to think that we have control so that this will never happen to us. I'll just tell you about another case in 1 minute, which was the mirror image of this. We had a young man who was in a motor vehicle accident in his 30s, had to have his leg amputated, severe head trauma, in the surgical ICU at Columbia. He was not married. His parents, who had been divorced, came together. They saw him. They spoke to the neurologist in the surgical ICU, said too early to make a determination what he's going to turn out to be like. They said, we want another opinion. The family got another opinion. Ironically, it was from the neurologist who happened to make the prognosis on this lady. And he came, and this time he hung crepe, as we said. Never going to be the same, not going to be the same. Whereas the surgical ICU neurologist says, too early. Ethics consult called, sat down, very tense meeting. Parents, in a way, and this is a situation I hate to be in, where I am arguing against the wishes of family that love the person, that it's too early, and the possibility that that patient may end up like this patient did. Anyway, we felt that it was, and at the time, the patient hadn't appointed them as a healthcare agent for legal reasons. There was probably an issue of their ability to withdraw life support. But taking that aside, we were prepared to go to the mat in that case. The consensus of all the doctors, except this one neurologist, it's much too early to make a prognosis. We will not extubate him. If you want to go to court, you may. The parents, disgruntled, said, okay. That patient made a 100% recovery, 100%. And the mother came to me in the hallway and embraced me and said, thank you for saving my son. So we don't know these things. Things turn out differently. We do the best we can. And I don't think we have absolute control over our medical destinies. We try, we have living wills, we have healthcare agents, and there's a limit to how much we can control. Having said that, I'm not poo-pooing having healthcare agents, proxies. I talk about having this all the time, but I think this case nicely illustrates the fact that, and you saw how thrilled this woman was initially, that there are limits to how much we can actually plan. I think, again, I think from the ethics point of view, we acted rather expeditiously. And to say that this patient should have been extubated on day 1 or 2, when the dust hadn't settled at all, I don't think you'll find many neurologists who would, in a case of traumatic brain injury, unless it was absolutely overwhelming, would be willing to do that so early on. Yes, sir.
Yeah, there's one piece of the puzzle I'm not sure. You said the patient supposedly stopped eating, but you didn't say there was a feeding tube. Where does that part of the puzzle?
No, he was able to eat, and we fed him. He did not get a feeding tube.
But later on, a month or two later, you said that he had lost interest in eating.
Oh, did the lady say that? Yeah, well, but it wasn't to the point where his life was threatened. He may just have not been his usual appetite. Good that you picked that up. But he was not given a feeding, not to my knowledge. Actually, I never saw the lady again. I just had her emails. A year later, by the way, she brought her husband in to see this neurologist who had been in the neuro ICU. And I asked him, how was she and how was the patient? And he felt that the patient was not quite as bad as she described, but clearly not himself. And he said, though, she was as angry as ever. I mean, it's a very tragic situation. Nobody here is saying it's anything other than a tragedy. But the reason I'm presenting it is because it's a tough case. And it is difficult to know. We try to do the right medically and ethically thing to do, and sometimes things don't work out as we would like it. Yes?
I had a question about your opinion on what you think the appropriateness is of really just disclosing odds of recovery at all at the very early stages, because, I mean, we know it's such an imprecise science. Mm-hmm. We know that some physicians are notorious for playing the odds, and some physicians are notorious for underplaying the odds. And so, when you have stakeholders and family members that are, looking to grasp onto that 1% chance and take it all the way through, what we would say maybe really futile treatments, and then families that say, oh, if there's only a 95% chance, then, the 5% chance that the patient won't recover fully, then we're going to pull the plug. Is there a different way of approaching this, because you have these stakeholders that seem to take whatever odds you give them and go in an all or nothing direction?
Yeah. Now, excellent question. I will tell you that this particular prognosis, I think, was unduly microscopic or granular, shall we say, unduly granular, 35%, 85% chance of a 30. I think you're also right in saying, and by the way, I lecture to the neurologists every year on medical ethics, and I say to them, you folks are in a unique position because based on your prognoses, life and death decisions are made. It's true in other areas as well, but when it comes to the brain, I think it's particularly relevant there. And families, they go by what the neurologist says. Now, having said that, there are some neurologists who will say in a situation like this at the beginning, I can't give you a numerical prognosis, but I can say it's too early to make a prognosis. It is conceivable patients like this have made full recoveries, and many patients have not, and I think those three categories of death, survival with impairment, and full recovery, when appropriate, they would say without attaching numbers to it. I think in general, it's been my experience, unless the damage to the brain is so overwhelming where no reasonable neurologist would say that there is any reasonable chance of any meaningful recovery, the doctors will say it is too early. And then we get into this situation of you have this window of opportunity of removing life support, and as patients get stronger and better, you lose that opportunity, and we then don't kill the patients, at least not today. Yeah.
And do you discuss that window explicitly with the families?
Yes, absolutely. We tell that. But very few families are willing, this is an outlying case, are willing to say, this is the window now, take them off life support. The doctor said it's too early, but we want the patient removed from life. And frankly, there might be situations where the doctor will refuse and say, I don't feel ethically at peace with doing it at this point because I think this patient has a reasonable chance. You have to call somebody else for another opinion. And there may be no neurologist, I haven't seen that happen. If no neurologist or physician is willing to withdraw life support, again, I haven't seen it, then I think there may be something wrong with the request. Yes, Barbara?
I would say also, as a profession, we should demand more studies that give our physicians better evidence and help them counsel families. We probably don't do enough tracking and trying to see what the outcome is. So you're limited to the single physician who in his lifetime has seen many cases, but that's not the same as looking at 50,000 cases and giving families better numbers. So it's just sort of one way to think about, how could we fix this problem? Well, one is we could get better numbers, better statistics. We could do a better job of tracking cases and putting more resources towards that to help families at this moment. But I think you all did. I just wanted to commend you also. A 2-day turnaround on a difficult case like this is amazing. You do wonder if they didn't call you in time.
Yep.
This lady had very specific stories about what her husband wanted, and so maybe they could have called ethics a little sooner for a better outcome for this family.
Yeah. It would have made our job more difficult. I'm sort of glad she didn't.
Sorry.
But you're right. No, you're right. They might have called us sooner.
Yeah.
Oh, assuming the patient made a full physical and mental recovery and was perfectly fine after the period of time, is there any precedent for the person coming in and asking what their agent's decision was, and then does the physician reveal that, or is it sort of something that is not usually touched upon by the patient?
In other
or
words,
the
when you
physician?
say, well, your wife actually wanted you to die and wanted us to, I've never had a situation where we have, actually there's a very interesting, I wrote an article called Substituted Misjudgment. The article is about a guy who was perfectly healthy, developed sepsis. He was a bricklayer, a masoner, and he developed sepsis, and he was in another hospital actually, and he developed gangrene of all 4 extremities. And the only way they could save his life is doing an amputation of all 4 extremities. And his girlfriend and his brother said, and he was on a ventilator, he was out of it. And the only way that he could survive was, and they said there's no way he would want to live without him. He never obviously discussed it. We don't think about these things, but who would want to live without their 4 extremities? I got a call from one of the members of the ethics committee who had happened to be a student of mine in pulmonary years before, and he asked my opinion. And my opinion was, and I had just read in the New England Journal of Medicine about these really major operations on men in Iraq who had been blown up by these explosive devices where they removed huge amounts. It was horrible, but to save their lives, and these people went to rehab. And I said, I think the key thing is his brain. I don't know that one can automatically assume that somebody in this day and age would want to die rather than have, he was in his 50s and so on. I said, I'd feel quite uncomfortable about it. This was in New Jersey, actually. Anyway, to make a long story short, the ethics committee there said, okay, we'll do it. The family wants it. They took him off the ventilator. As in this case, he did not die. The patient was then approached and said, here's the facts. You want us to go ahead and take off your 4, or do you want us to let you go? He said, do what it takes. Those were his words. Do what it takes. They did 4 amputations. The man who had called me for the consult went to see him the day when he went for his rehab, and he thanked him profusely for saving his life. Now, did we tell him that his girlfriend and his brother said, let him die? I don't think they did, but your question reminded me of that case. And here again, this substituted judgment, it's very difficult. You know, all of us sitting here healthy and robust and so on, you look at somebody in the hospital, oh God, I wouldn't want to be like that. And when you're staring death in the face, folks, let me tell you, you're willing to accept a whole lot more than you think you would be willing to accept. And that is a statement of fact. No question. I don't say everybody, but the vast majority of people. We can put up with a lot of disability and so forth. This is the one life we have, and people learn to live with it. So that's sort of my message for the day. Okay, well, I guess thank you all very much for your attention.
Please join me in thanking Dr. Prager. And we hope you'll join us for our next event, which is on October 11th on the main campus. We have Ron Bayer and Harriet Washington talking about our new joint degree program at the School of Public Health and Bioethics, and the importance of bringing those 2 fields together. So thank you all for coming, and we look forward to seeing you again. That was great. What was his mental state like?